Yes, there we go. We have the technology sorted out. So you'll be glad to know that by the end of the lecture, you'll not only be hungry, but you'll be able to compare the differences between the typical normal and abnormal appearances of singleton pregnancies, of monochorionic and dichorionic twin pregnancies between 10 and 14 weeks of gestation. So I hope all your alpha waves are switched off and that you're alert, because that's quite a daunting task. So our key questions are, forgive me for looking away from you because what's there is different to what's here. So basically, and the first really key question of ultrasound, and I think one of the few places where ultrasound has really proved its own in obstetrical care, is determining gestational age. And it really starts with, how do you determine gestational age, and combined to that, which also not always happens correctly, how do you assign the expected date of delivery between 10 and 14 weeks? Secondly, what does the normal fetus look like between 10 and 14 weeks? And then which structural abnormalities can you, as mostly basic scanners, when you start scanning on Monday, hope to diagnose in this time period? And then something also very close to my heart, what's the principle? Sorry, I'm just going to... Right. Good. Right. And what's close to my heart, the difference between monochorionic and dichorionic twins in this latter part of the first part of the second trimester. Right, and just a word about our sponsors again of ISUOG. And you can visit the ISUOG platform. There are lots of free CME credits. I don't know if there are specific ethical credits, which we always have to attend the MPS lectures for. But you'll be able to log in. And I see here Ali Yusuf is still logged in. And Ali Yusuf, he might have trouble getting into the United States now at the moment, but he fortunately works in Bologna with Pilu, and you'll see lots of articles from Yusuf and Pilu and the rest of the other guys from Bologna, also home of spaghetti. Be prepared to be lost to the rest of your family and loved ones as you browse around there. Now, I think what we really should do is just to have this picture up for the next half an hour, and that you just look at it and look at it again and look at it again. Because Shannon told you that when you scan, what you should be doing is really make the image big. I mean, you paid for the machine with that huge monitor, so you use that huge monitor. And getting a beautiful crown rump length like this isn't that difficult, but the only way to know that it really looks like this is making it as big as that. And I remember at somewhere I had to give a talk, and I realized I wanted to show a nice picture of a crown rump length, and I didn't have one. And at that stage, I was still in Utrecht, and I could actually log into what's happening in the ultrasound unit remotely. And I said, oh, okay, there's a sonographer who's going to do a first trimester scan. And lo and behold, the first picture came up like this. I was really so happy to know that here I am halfway across the globe, and it's just the sonographers just carry on doing what they should be doing. So really, if you forget anything else, what I say in the next half an hour or so, just remember, make your image big. Make it really, really big. Make it so big that, that baby really jumps off the screen at you. Right, now, so a grade A recommendation is that pregnant women should be offered an early ultrasound scan between 10 and 14 weeks to establish gestational age. And of course, there is a little bit of a twist in the tail, because how do you know she is between 10 and 14 weeks if you haven't done a scan to establish the gestational age? So what I believe the NHS does is it uses the menstrual period just to determine the time of this timing scan. And if you see someone at 7 weeks, it's okay to do a scan and tell her, well, I think you're more or less 7 weeks. But that means I'm going to see you 5 weeks from now to do a decent scan, and then we'll determine the EDD. And we're going to determine it then, and we're not going to shift it by 1 day forward or 1 day backwards. And I'm not going to tell you now. I'm going to tell you it's somewhere in October. So tell your husband not to go wherever, what kind of a big cycle tour is in, not to do the Karoo to coast or whatever. But I'm going to tell you exact date. I'm going to tell you 5 weeks from now. So basically, between 10 and 14 weeks, and that's in other words, what's the crown rump length at 10 weeks? How big is the embryo at 10 weeks? Oh, you don't need to shout it out, you just show me. I've got this, I've got that. Anyone? Yeah, who knows? 25 millimeters, 30 millimeters, something like that. And I can tell you what is at 11 and a half weeks, and it's 48 millimeters, because below that we shouldn't be looking at nuchal fluid, but that's another talk. And at 14 weeks, how big is it? It's actually there. It says 84 millimeters. So it's easy between 48 and 84 millimeters. Now, I know it's not 48, it's actually 45, but then it doesn't work. So between 48 and 84 millimeters is the time when you can use a crown rump length to determine gestational age. Below that, if it's 30 millimeters, 20 millimeters, 15 millimeters, I don't know how low your machines go, 5 millimeters, don't determine the gestational age. Say, congratulations, you're pregnant, I see the heartbeat, I'm not going to succumb to the temptation of the granny that's also in the room, says, oh, I just want to listen to the heart. You just watch your heart and say, come back, and then we'll do the determination of the gestational age. Now, of course, now and again, women arrive that are, now the crown rump length is 90 millimeters. So how do you determine the gestational age now? Tell her, come back last week, and then we'll do it for you. Now we use the head circumference. So go to the trouble of measuring the head circumference. It's also been shown that the head circumference is more precise than the biparietal diameter. So again, basically determining the gestational age, I think we've got a nice algorithm on the next one, is if this woman is pregnant after assisted reproductive technology, and that's what Amos has been talking about. It's someone that's had her uterine septum cut out and she's still not pregnant. Now she gets ICSI, and I mean, she can tell you probably to the second how far pregnant she is. And of course, our infertility colleagues get it wrong, because they know to the second when that pregnancy was conceived. I mean, they can, on the microscopes, they've got the millisecond when that sperm enters the egg, and then they wait 5 days and they put back the embryo, and then they say that's when the pregnancy started, which is, of course, utter rubbish. And then you get into huge fights with them. But of course, you know, that's part of it. So if it's after assisted reproductive technology, you use that date. And of course, if someone's had an artificial insemination, do you use that date? 2 days later. Emma says 2 days later. Okay, if someone's, okay, so we've had IVF, then you know conception date, you use that. Artificial insemination, Do we use that date? Who says yes? I see a couple of this. Who says no? Why not? Yeah, okay. It might be not the artificial insemination. It might be the husband. It might be the... Yeah, so we want to know the conception date. And of course, it might be that she only ovulates afterwards. So she might only actually fall pregnant a day or two later. And it might be that the neighbor across the road was visiting 2 days previously. So who knows? But in any ways, that's not going to be a big time frame difference. So if it's a spontaneous pregnancy, does she know when her last period was? Yes. Is it reliable? And what else do we know to make the last period reliable? When was the first day? And I see someone showing this. It must be regular. And what must she not have been doing in the last 3 months? Breastfeeding or using contraception? If yes, then ISUOG says you change the EDD only if it differs more than 5 to 7 days from the menstrual history. And that's fair enough, and it's an international organization, so it's you can go by that. There are other voices that say you just ignore this and you go by the ultrasound only. Disadvantage of that, and why don't we want to just ignore the menstrual history or ignore what the infertility guys say because they confuse us anyway? What do we want to detect at 12, 14 weeks? That would be useful if there is really a discrepancy between our ultrasound dating and the clinical dating or historical dating. Sorry? Yeah, I have to shout, sorry. No, why it's always good to take the menstrual history into account as well, and definitely the IVF history, is because in triploidies and some trisomies, the embryo is a lot smaller at 12 weeks already than you would expect. So if there is a big discrepancy, it's always good just to use your brain as well and not just make an easy algorithm. Okay, now the EDD is 10 days later or 7 days later, now I'm going to change it. So just think it through as well. But practically, it's nice and easy. ART, use the ART date. Menstrual, use the ultrasound date if it differs more than about 5 days. Okay. Right, so this is a nice example of all of that. Now I must just stand here that I can see. So she has now 12 weeks, 3 days of amenorrhea. EDD is the 15th of January. On ultrasound, we see gestational age is 11 weeks. The ultrasound EDD is now the 25th of January. And I think, Katja, tell them they should really update these to 2017. They must have something that just takes a date from the presentation. And so if it corresponds, you just say in your little note at the bottom, either to yourself or to whoever will be seeing the patient you're scanning now, that the ultrasound dimensions correspond to the menstrual age. In other words, the EDD equals the menstrual EDD. Or you can say there's a discrepancy of 7 days or 10 days, and therefore I reckon the EDD is whatever the ultrasound says it is. And just state that clearly, write it clearly on your notes. If you have the patient's antenatal card, make sure it's on there, because there's no end to the amount of disasters in labor ward and with lots of consequences for the patient, for the baby, and making the lawyers rich if we manage to mess up the gestational age. Maybe I should just stop and ask if there are questions so far. Yes, there is a question. Okay, sorry.
it's not actually a question, it's a comment. My observation is that the trend among females nowadays is that they really, really don't remember when last they had their last menstrual period. They'll always tell you about when. So the only thing which you can now rely on is basically ultrasound. I don't know what's your comment about that.
There's a lady just behind you that looks as though she might comment on your comment.
Can you hear me? Oscar, here in the Cape, they all have apps. They know exactly.
Okay, right. There's another. Okay, so someone else that concurs that just tell your patient to get an app. But I don't know how that works. And Ermos.
I think important to mention here, because we all rely on the ultrasound machines to tell us, based on the crown to rump length measurement, what is the gestational age. You've got to be familiar with what formula has been used on your machine to establish the exact gestational age, because different formula, Hartlock, let's say, will give you a different gestational age to Robinson, which is the one that the FMF uses for the determination of the risk of chromosomal abnormalities. So 40 millimeters, for example, with Hartlock will give you 11 weeks, but 40 millimeters with Robinson will give you 10 weeks and 3 days. Yeah, and I think it's important to know what formula is being used in your machine to be able to establish exactly the gestational age.
Ermos, thank you for that, and I think that's a really, really valid point. And go back home, check your ultrasound, and if it's got any other crown rump formula except for Robinson, just delete it. Just delete it. Don't make a backup, just delete it. And it's interesting, if you look at Robinson's article, I mean, you really have to struggle to find it. You really have to take your hat off for them for getting such good data that even good studies from now, there was one recently from Belgium. I can't remember how well the intergrowth compared to that, but where you can really get these nice big crown rump lengths that everyone can drool over, it still shows the same as Robinson. So ignore everything, just go with Robinson. Right.
Even the one done in Rotterdam with the virtual reality, by blowing up the fetuses, very similar.
Yeah, and what Professor Ballard was saying, in Rotterdam, they have this virtual reality room where if you ever visit Rotterdam, try and wangle away to go this year, put on 3D goggles, and they actually display this first trimester fetus as big as this in front of you. And you can turn it around and slice through it, and it's really, really amazing. And even with that, they got the same results as Robinson. Right. Okay, so now we want to see what can we see normally in a fetus. So now we've determined how far this woman is, or how far the pregnancy is, and despite what her app says, what the ultrasound says she is, now we want to see, physically what do we want to see, and what's in red is what really, when you go home and you practice what you've heard today, that's the red is what you want to see. And then as you get better and better and start drifting away from the ISUOG website to the Fetal Medicine Foundation website and start accrediting for things like nuchal translucency, the rest is what you will then really learn to do. So basically, the first thing we want to see of the fetus is, does it have a head or not? And except for politics, without a head, you're not going to get very far. So is there a head? Are the cranial bones present? Is there a falx? And are there choroid plexus filled ventricles? So you see the head is almost as much as the rest of the baby put together. Going down from the head, you want to see, does the neck have a normal appearance? Go down, still into the chest. Are the lung fields symmetrical, no huge masses or fluid collections or asymmetry? Does the heart beat regularly? Is the umbilical cord, now still slide your probe down the baby, is the umbilical cord inserted normally in the abdomen with no umbilical defects, and then you branch out laterally, and are there 4 limbs, and does each limb have at least 3 segments with bits and pieces at the end of it? So that's really what you want to know. The head, in other words, the head is there, the cranial bones are there, there's a falx, our choroid plexus filling the ventricles. Does the neck look fine? Do the lung fields look normal, symmetrical, no masses? Does the heart beat regularly? Is the umbilical cord inserted normally? And are there 4 limbs, each with 3 segments? And I mean, we can go into all the rest of it, but I'm not even going to talk about it. I think you probably get the slides, but anyway, you can probably log in afterwards and get a hold of this. But that's really what's essential in any fetus that passes underneath your hands between 10 and 14 weeks that you want to know. Right. So we start with the head, and as we said, firstly there is a head, the head's present. We can actually see that there are cranial bones, and if you look at the head, you can see there are the brighter white bits, and those are the cranial bones, and in between are the membranous pieces of the bone that still need actually bone to grow in there to close up the fontanelles. There's a falx running down the midline, and if the falx doesn't run down the midline, why isn't it in the midline? Yeah, so it can be that you're scanning the baby incorrectly, and that's always in terms of.
This one.
Okay, it's just different here than there. Oh yes, yeah. It's just what I see on the screen and what's on top differs. Anyway, while you're sorting that out for us, so if you don't see the falx in the middle, either the falx isn't there, and then we'll come to what the reason is for that. And if the falx doesn't run down nicely down the middle, chances are that it's basically your fault and not the baby's fault. That you're scanning through the head at obliquely and not axially. But it is always dangerous to assume that when you don't see a normal picture as you expect to see it, that it is your fault and not the baby's fault. And that's the one thing that grows with experience, is that you start knowing that, I normally should be. Yes, good, thank you. Good. We're in. Okay, good. All right, good. Yes, good. Right, good. So, so there's the red marker on the falx. So, as experience grows, then you'll start knowing that, I've tried my tricks, and if I try my tricks in the other past 10 babies or 100 babies or 1,000 babies, I manage to see this now. I don't see it. So in other words, it's the baby's fault. And usually, where studies have been done to look at ultrasounds that have been done in undiagnosed abnormalities, and I think the biggest one I know was in cardiac abnormalities that have been found, is if the time of the ultrasound examination is compared. You would think that if an ultrasound, and put it the other way around, an anomaly is missed. This is a baby with an AVSD, but it wasn't picked up on ultrasound. Would you think the ultrasound examination was the same as average, shorter than average, or longer than average? I hear quite a few shorters because your own bladder is full, or you're hungry, or you're tired, or fed up, and you rush to the scan, and not true. Often, the average scan is longer than average, or for that specific individual, of course. And what probably happens is that you don't get the picture you see, you struggle finding it, and then in the end you decide, you know, I just don't see it well for whatever reason. The woman is just is an unfortunate fetal maternal ratio, so I don't see it well, or whatever. Or she used Vaseline and that interferes with my ultrasound gel, whatever. And then you decide it's okay. And that's basically, I think, important as you go out and you start practicing this. There must be someone as a backup close to you that if you don't see these pictures, that you can just ask them, someone says, you know, I don't see the felts in the middle of the head, please just check with me. And the first 20 times they're going to say, just do this transducer little bit and says, okay, there it is, and you feel, okay, foolish, but just persist and persist and persist, because the 20th time you won't see it and you come in, okay, you know, what do you want to see, and then realize that you have actually picked up an anomaly. Right. So that's the head. And in the neck, basically, you want to know that there's a normal appearance of the neck. And if that is the head, then that's obviously the neck. And the neck goes from front to back. And we're especially interested in what the nuchal translucency thickness looks like. But please, if you haven't had specific training to measure the nuchal translucency, don't go measuring it, because you'll be measuring it incorrectly, and the next thing you tell PathCure or Ampath or Lancet, you know, I've measured the nuchal fluid 1.1, and they give you a risk of Down syndrome, which is completely inaccurate. So just look at it, just make sure that this amount of fluid behind the baby's neck looks like what it's supposed to look like. And of course, the first 1 or 2 or 3 babies, you don't know what it's going to look like, because you still have to get used to what it looks like. But if you scan and say, this really looks thicker, and now I don't only see fluid behind the neck, but it also comes around the neck, then something's wrong. Okay. Right, and this is now the, for once you're scanning at a higher level of scanning, where you start looking at the eye, see a normal profile, normal nasal bone, palate, mandible, all really beautiful. On the axial section, the eyes with the lenses, normal upper lip. And of course, with the machine that the hospital superintendent bought 15 years old on a budget second-hand from Korea, isn't going to show this to you. But as you get better and get better equipment and scanning with higher resolution equipment, this is what you'll start seeing. And scanning down the spine, you'll appreciate exactly the same elements of the spine that you will be looking at 20 weeks. In other words, vertebrae with intact skin. And if you're really good with really good equipment, really good visualization, you can even start making out the spinal cord as well. Inside the chest, and this is now again essentially what you should know, is that there are symmetrical lung fields. Of course, the heart is not symmetrical in exactly the middle of the chest, and there are no huge effusions or masses. In other words, it's got the same kind of bland shade of grey or sepia what you're used to. There's not black there, which is an effusion, or bright white, which might be some kind of mass. In the heart, you see nice equal size right and left chambers, the valves on the right opening and closing and beating along nice and regularly. And you'll notice there's nothing about putting on M-mode, putting on pulse wave. If you see it, that's actually fine. That's what you want to see at this basic level. Then as you scan down, you can see these are mostly still longitudinal views, because that's, once you get to the nuchal translucency, how you'll mainly be looking at it. See the stomach, the bladder. If you really start getting good, you can see the kidneys. And the stomach you really want to be able to see. The bladder, depending on when you scan, if you tend to see the pregnancies more for gestational determination around about the 10, 11 weeks, you will more often not be seeing the bladder that easily as when you're scanning more for late first trimester evaluation, let's say 12 and a half, 13 and a half weeks. And please just stop me and wave if there's any question about any of this. Abdominal wall is important enough that this they've really shown you in a sagittal and an axial view, and also not without reason, because it's really good to evaluate a cord insertion not only sagittally but also axially. And then as we then proceed more peripherally, what then needs to be seen is that there are in fact 4 limbs, 2 arms, 2 legs, and each with 3 segments. In other words, 2 humeri, 2 radii, 2 ulni, 2 femora, 2 tibia, 2 fibula, and then with hands and fingers. And once you get used to this and are scanning at a more advanced level, that this is not only gestational age and sorting out the worst of abnormalities, but also an earlier anatomical evaluation, make sure that the hands are in a normal position and that the fingers actually open up, and the babies are usually much more obliging at 12 weeks, and you can very easily see both hands at the same time. And when you scan at 23 weeks and one arm is lying behind the baby and the other hand's waving around, and you see the hand this side and that's the left hand, you see the hand that side and that's not the right hand, because the right hand is actually missing. And that's much easier to pick up now than later on. Also feet in normal position, and of course all of us start off life with club feet. If you look early enough, all of us have club feet, so don't look at it too early, but in this time frame from 11 to 14 weeks, the feet should be in a normal orientation as well. Right. And then placenta, normal size, normal texture, and again, you see there's color, and again, as we told you, we're careful with using any kind of Doppler, including color Doppler in the first trimester, but the free vessel cord can also be beautifully well seen in the late first trimester. And again, if you're an expert at scanning, then you will be able to see all of this much more quickly. If you're not an expert, please don't switch on the color Doppler and then start trying to find the cord or whatever, because it will just take so much longer and bombard the fetus with just so many more ultrasound waves, which we don't really know what the effect of that really is. Right, so what should we detect? What we should really not miss at all would be the future politicians, the acranias, anencephalies, those, the future lawyers, those with a heart that's not in the right place. And, well, I want to say some of my best friends are lawyers, but that's not quite true. But, you know, I'm not really against them. I think it's like all elements of the society. We need each other. Otherwise, where would jokes come from? And so, acrania, what's acrania? No head. Anencephaly, is that the right term to use now? I'll show you later, but it's not actually the right term for now. But maybe anencephaly is a kind of picture of the term infant, that where the brain actually ends, where the skull ends at the base of the skull. So there are eyes, but nothing above it. Ectopia cordis, who's had Latin at school? Well, the heart sits outside the chest, so that should be easy to see. And encephalocele, and of course there can be tiny encephaloceles, but any huge encephalocele we should be seeing. And of course at the other end of the scale, there are things that we're just not going to see. And those are things that only develop later on. Corpus callosum agenesis, because the corpus callosum isn't there to be seen. Cerebellar hyperplasia or vermian hyperplasia, because the vermis just isn't here yet. Renal agenesis, bilateral renal agenesis we should be detecting because there's no bladder. And I've missed one in this last year that I shouldn't have missed because I fooled myself in believing that I saw a bladder, which there wasn't, and that is something that we should actually pick up. And then lots of other stuff that's only going to develop later or start showing themselves later. Duodenal atresia, lots of that stuff, it only starts working later. You're not going to see it now. And if we go to the FMF congresses, there's really this drive of, look at 12 weeks, going to see everything at 12 weeks. And lots of that is true. And I really believe that what we can detect at 12 weeks, we should detect at 12 weeks because it's just so much less traumatic picking up something at 12 weeks than at 22 weeks. But it just is a fact of life that this is work in progress. Lots of what we would be able to see in the third trimester, we would not be able to see yet. Then there are things that we really should see as well. Cystic hydroma, those big pockets of fluid in the neck, the really bad heart diseases, abdominal wall defects, holoprosencephaly, where the two brain halves are fused, so there's no falx, megacystis, limb reduction. Polydactyly can be detected now, and more than 50% in units that are good at this would detect it. And then we're really bad at detecting spina bifida, which we should be better. I know Fred, what's his name, works in London, Yusakov. He says that 100% of spina bifida should be detected at 12 weeks, and then everyone quiets him down in case there are some lawyers listening. Right. So this also has to do with the timing of the scanning, and the same as what I said of bladder holds true for the other abnormalities. And around about 11 weeks, less than half the major abnormalities would be seen, whereas at 13.5 weeks, you can get to up to 3/4 of those abnormalities. And the pictures on the right just show, and of course they really chose a crappy picture of 46 millimeters and an excellent picture of 78 millimeters, but the message is clear that just between 40 millimeters and 80 millimeters, that fetus is twice the size. In other words, it's 8 times the volume. And although we scan in slices, our brains interpret volume as well. So it's just going to be much easier to detect it when that fetus is slightly bigger. Questions so far? Right, so let's go and look at a couple of abnormalities. What's wrong with this poor baby? Is there anything wrong with this baby? Yeah, you can't really figure out what's head and what's tail, hey? So it's, well, believe me, that's a baby's tail end. There's a stomach, there's probably an arm, and there we can see the whole cranial vault is missing, and it's a bit irregular here. And why is that? Because there's no skull, and so there is still more brain tissue than you would see with a term infant with anencephaly, but this is why it's often now referred as not anencephaly, but exencephaly. And look, there the baby's moving, and now you can see it much more clearly, the face over here, and the brain actually floating around a bit. And which is why in the earlier days this was often missed, because if you have a quick look, you can measure crown rump length, and you really need to look and look again to make sure that there's And then you can appreciate that there's not a rounded vault of the brain. Right, this made it easier for you. A normal one, that side. What don't we see in the other brain? Falx, yeah. So we don't see the falx running straight down the middle. So instead of a ventricle here with choroid plexus, ventricle here with choroid plexus, we have this horseshoe-shaped ventricle. And what does this baby have? Yeah, so alobar roller prosencephaly. In other words, holo means whole, pros is front, and encephalon is brain, so the front of the brain is all one. But you can see it can move around and jump around happily despite of that. Right, some other neural tube defects. Encephalocele, and that's that one that the encephalocele that you really shouldn't miss. And you can see if you're in a hurry and the baby's lying with the head right back up against the wall, this encephalocele might be compressed and you might not see it. So allow the baby a bit of time to move around. And this is a baby, you can see 2 legs and a bladder, but you can just see everything's really horribly wrong. It's a very foreshortened baby, so there is an encephalocele. I also don't really see very nice cranial vaults, but probably enough to keep the brain intact. And the severe spinal malformations, a very foreshortened spine, maybe something like an iniencephaly. This baby, nice profile or not so nice profile? What's wrong with this baby? Is it, well, let's start with the head. Anything with the head that's bothering you? Yeah, it's got a very big forehead, eh? And then we see the chin nicely on the chest. There's the chest and there's the stomach. So it feels like a really, really long time since New Year, but it looks like a bit of a champagne cork. So the narrow part of the chest and a big part of the stomach. So again, not something that you should put this label now onto the patient. And the same as Douglas said, you don't tell this girl of 18 that she's going to have several miscarriages if you see an arcuate uterus. If you're not used to scanning, you're not going to put this label on that says it's a lethal skeletal dysplasia. But this would really be a prompt for you to send it to someone that can do a good evaluation. And the reason why it's a lethal skeletal dysplasia is not because it's got a big head, but because it's got a small chest. Right, and still with the faces, this baby. Previous one's forehead looked too big, and now if you draw a line through the tip of the chin and the base of the nose, it runs through just through the forehead. So that previous baby, if we draw the line through the tip of the chin, through the base of the nose, you can see there's a huge part of forehead in front of that. So it's got too big a forehead. This baby, if we draw lines through the tip of the mandible, through the base of the nose, then it runs in front of the forehead. So either the forehead is too small or the mandible is too small. And which of the two is it? Yeah, so its mandible is too small, so it's got a micrognathia. It looks a bit like Bart Simpson's dad's boss. What's Homer's boss? Forget. But anyway, it looks a bit like him, with a very small, tiny chin. Right, and I know some of you are feeling a bit like this at the moment, so I really promise I'll be finished before too long. So this is a baby with a huge, huge bladder. That one also has a huge bladder, not quite that huge. And that is, well, I should have told you it's got a cystic abdominal structure, but we're getting close to lunch, so it's a big bladder. And it's megacystis, and in this time frame, megacystis is not a bladder with more than a liter in it, but it means a bladder that's more than 7 millimeters long. And I think for now, for a basic course, you really just need to know the magical finger of a number of 7 days in a week. On the 7th day this week, we won't be getting our rest, so we'll double up next weekend. But more than 7 millimeters is too long for a bladder, and you just measure it from the bottom to the end, as they've measured here for you. This other baby, once it stops moving, I'll show you. And yes, from there to there, we measure it more than 7 millimeters, too much, and refer. And if it's a little more, it's got a bigger chance of chromosomal problems. It's a lot more bigger chance that its kidneys will get stuffed. But you know, I think for now, just know that more than 7 millimeters is not a good thing. In the vicinity of the bladder again, here we see again color, a bit naughty, but we see color there. So we actually see the umbilical cord running inside this lump on top of the baby's stomach, which is of course, yeah, omphalocele. And why omphalocele, not gastroschisis? Because it's got a membrane around it. And what should we be careful about calling an omphalocele if she's less than 11 weeks, or less than 11 and a half weeks, and even occasionally after that? Well, we all started out life with a physiological omphalocele, if you want to call that, a physiological bowel herniation. And the clue is it's a lot smaller, and by 11 and a half, definitely 12 weeks, it should be gone. And this now is its twin or cousin, which is, again, you see the umbilical cord which sort of runs to the side of it, this little cauliflower-like mass. Yeah, so gastroschisis, exactly right. And okay, this gets more tricky. You know, you really have to be alert. You know, you have to, there's no such thing as a free lunch, eh? So you have to work for it. And let me just take the marker out of the way, that you don't think the problem is where the marker is. So what does this baby have? Well, it's got something here at the bottom of the spine. Okay. And of course, now the first thing is some kind of cyst at the bottom of the spine. What's the first thing you think of? Spina bifida, of course. There's a spina bifida, a cystic lump at the back of the spine, and often the diagnosis would be a bit like chess. Who of you plays chess? Who of you knows the chess moves? Well, anyway, if you play chess and you know, then you're in this real competition, you think of a move, and then you spend the next 10 minutes sitting there thinking of 20 other moves and try and figure out with each of those moves what are the next 3 moves of your opponent. And in the end, you make your first move that you thought of. And but this time it doesn't work like that, because this isn't the spina bifida. Why? Because this is in front of the spine. And you can actually also see, for those that want to think a bit further, you can actually see there's quite a nice intracranial translucency, which would make a spina bifida also less likely. And that's sacrococcygeal teratoma. Right. So I'll take the last couple of minutes for twins. And twins are easy. You know, twins are easy. All you need to know, you need to count to be able to count to 2. And the only other thing you need to know is if the 2 are a different size, is one at 14 weeks, 10 weeks, 12 weeks. Would an abnormal one be too big or too small? It would be too small. So in other words, if the 2 size differ, which one do you take for gestational age? The big one, right. So don't go by the average, don't go by the smaller one, don't go by what the infertility guys tell you, you just take the big one. Right. Then labeling is the next thing, and there just describe clearly what you see. You know, if one baby sits just above the cervix and then there's a membrane above that, then one's always going to be below and above. If the membrane runs up and down into the cervix, then and it runs front to back, then one's always going to be right and one left. The membrane runs down, but it runs down coronally, then one's going to be in front and one's going to be at the back. And then the main thing is chorionicity, because the whole of management is depending on the chorionicity, and if you get it wrong now, at 16 weeks, 18 weeks, 20 weeks, 32 weeks, people are going to be swearing at you and you don't know why. Suddenly there are rats on the ceiling and your car gets a flat tire and all sorts of things that are wished on you because you didn't get the chorionicity right. So just get the chorionicity right. And you don't need to get anyone to exercise and whatever. So, and it's not difficult, it's easy, but it's also easy to get it wrong. And basically, the lambda sign, and it's a Greek lambda, that's a L, so it is a little triangle, and that means there's, chorion that is pulled up into the dividing membrane, and that means it's dichorionic. So 2 sacs, 2 placentas, and those are twins that are just by chance sharing the uterus at the same time, and you know those are the easy twins. You know, anyone can look after them. Then thin membrane just runs slam with the T sign into the wall of the uterus, but still there is a membrane, so those are still diamniotic because there are 2 sacs, single placenta, and those are the ones you really have to be careful of. And those are the ones that you say, I know you wanted to spend your money on a new watch or whatever, but you know you need to have someone looking after you that knows what they're doing. And if you see no membrane, that's actually wrong. If you see no membrane, what's your first, second, and third diagnosis? Now, if you don't see a membrane, chances are you're not looking at the right spot. If you don't see a membrane, don't immediately tell the patient this is monoamniotic. Just say, I don't see a membrane. I'm going to refer you to someone before your biggest baby is 84 millimeters that they can have a proper look. Because if it's really monoamniotic twins, then you start thinking of all the complications of monoamniotic twins. So this is really not a diagnosis to be made in your own. So basically, if you think there is a lambda, get your buddy who knows how to scan, that's been used to it, take a picture, get the parents, say, you know, you've got a smartphone, take a picture, just keep this picture at all times, print it out, staple it to the notes, get him to paste it on Instagram, Facebook, whatever that. At 32 weeks, when there's a problem, is this monochorionic or dichorionic, they can just show the managing obstetrician says this is a dichorionic pregnancy, you can relax. Or else. Right, chorionicity and zygosity, I'm not going to even speak about because identical or not, you know, it's irritating, don't even worry about it. All you need to know is, do these babies share a placenta or don't they share a placenta? And again, I'm not going to spend any time with that. The only thing you want to know is on... Okay, now I've really confused this computer. Let's just see if this is going to work now. Yes. So what you really want to know is on the screen. So basically 2 pictures that are burnt into your retina. And the one was that first great huge big crown rump length. And if you do a scan in 10, 12 weeks and you don't get a great huge big crown rump length like that, you know, feel ashamed of yourself. And if they are twins, just don't even look at the crown rump length till you've seen this. Either this one and you get your body to confirm it, or you see that, or you don't see anything at all like that, and you refer and you ask someone that knows about twins and early scanning to sort that out. Right. Good. So once we get to the key points, you can relax, and you know lunch is now really in sight. And so early scan between 10 and 14 weeks. First trimester, it's the same as that 6-point is, you know, hello baby, where are you? Are you in the uterus or not? Are you alive? How many of you are there? Where's your placenta? You know, do you have enough water, and how big are you? It's basically that same. And then if you know how to do it and the patient wants you how to do it, then you can do a more formal evaluation of the morphology and the aneuploidy risk. But that's a whole different topic. That's don't go there at this stage. Remember that many things can only develop later on. And in twins, chorionicity should be accurately determined and documented and documented and documented and documented. And that's it. More questions?
Thank you for your humor that made indeed waiting for lunch less heavy. So let's have a look if we have some questions.
Oh, okay. Thanks. Oh, all right. Okay. So while we're looking for the live streaming, any questions from here? There's one.
Looking at a fetal spine in a longitudinal view is always the easy one. The intact skin and looking at the intact vertebra. The axial one is the one that I find difficult. How important is it to accurately look at a spine in the axial view when you have a normal longitudinal view?
No, the axial view of the spine is actually a cop-out if you don't see the spine in a longitudinal view. So it's after the sagittal view, the next most important one is the coronal view, because the sagittal view is really to look for spina bifida. The coronal view is really to look for hemivertebrae, and the axial view is really to determine what you've suspected in one of the others. So with the spine, it's really one of the things that I think somewhere around here we also said that you have to have a protocol and go according to that protocol, that you see head and then face and then neck and then heart. But the spine is the one exception, that if at the start of the scan the baby lies with the spine anteriorly, then I go look at the spine. And in between, as the baby turns, if he turns to the spine anterior, that's the time to go look for it. Otherwise, you do the whole scan of half an hour, 3/4 of an hour, and the spine is lying now posteriorly, and then you can't evaluate the spine very well. So it's really, unless you've seen the spine in a sagittal view, with the spine anteriorly, you haven't evaluated the spine properly. And the axial view is a poor substitute for that.
We have here a question from Amazulu, from Kaya Nzimande, who asks would the presence of a meningocele or spina bifida have any impact on the ultrasound gestational age determination in between 10 and
Okay, yeah, that's a good question, whether meningocele or spina bifida would affect the gestational age. And of course, it depends how bad it is. If it's a really bad spina bifida meningocele with severe kyphoscoliosis, it is going to mess up the crown rump length. On the other hand, if it's a small sacral meningocele, it's not going to have an effect. And if it is someone that wants to continue the pregnancy, maybe that is one to wait and look at the head circumference, but that's also going to be affected by spina bifida. So that is one place where it's more difficult to get it accurately.
especially the BPD.
Yeah, especially the BPD. Ermos.
Thanks, Don.
Is it fair to say if we see an abnormality at 12 weeks, whether it's spina bifida, whatever, unless it's really very clear and unless you're very experienced, is it fair to say rather don't do anything, let's not rush into terminating and bring that baby back in 2 weeks and have another look? Yeah?
Yes. Amos, I think you are absolutely right. And in the first trimester, I'm much more worried about false positives than false negatives. Because we all know as we go into uncharted territory for ourselves, how easy it is to overinterpret findings. And I think we've all seen those babies who were really, really worried. I had to look 2 weeks, 4 weeks later, and it comes back to normal. So please don't overdiagnose. I think the aim is to detect it then, but you know, some things are abundantly clear and then there's no doubt. But spina bifida, heart lesions, anything else, please rather take the time, review 2 weeks later, 4 weeks later, and then make a final decision. There's a question.
In your experience, what is the significance of the abnormally big bladder? Because I saw 2 of them in 2016, and both of them were in mothers above the age of 40.
Right, yeah. So the question is the significance of a big bladder or megacystis, and definitely more than 7 millimeters, there is a high risk of associated chromosomal abnormalities, and that I would be mainly worried about in a woman above 40. Once it goes over 16 millimeters, there's a big chance of severe lower urinary tract obstruction as well. But of course, especially in the lower range group, 7 to 14 millimeters, there is quite a significant group where it can resolve spontaneously without any effect. So it is a marker of a problem rather than an absolute diagnosis in that sense.
So another good example of where you have to wait and bring the patient back 2 weeks later.
Yeah, exactly. Another good example where you have to wait and see later again, or do further investigations. See any other things?
Well,
from
there are
online?
2 other questions, but in actual fact are gynecological questions.
Oh, Douglas.
You
Yeah.
want to? So one is from Nigeria. What quantity of fluid is normal in, I think,
Pouch of Douglas.
PID?
Pouch of Douglas.
Okay, pouch of Douglas.
Once again, depends on whether it's premenopausal or postmenopausal. So any fluid in the postmenopausal woman, the pouch of Douglas, is abnormal and needs investigation. In the premenopausal woman, I mentioned the different levels. So if you're seeing fluid up to the fundus of the uterus, that's abnormal. If you're seeing the fluid in the anterior uterovesical pouch, is abnormal. And obviously, if you're seeing fluid high up in the abdomen, around the liver and the kidneys, is abnormal.
And then another one. How do we differentiate between corpus luteum cyst and hemorrhagic cyst if both give spider
Spiderweb
appearance.
Yeah.
It's got a Nigerian spell check.
Ah, okay.
Spiderweb appearance.
I mean, it's essentially the same thing as whether if you've got a hemorrhagic cyst or a corpus luteum cyst that's hemorrhagic, they get managed the same way. And that's basically conservative management with pain relief and rescan in time. Normally 2 months to 3 months' time.
Okay, thank you.
Maybe I should just add to that in case I'm, someone's worried about xenophobia. My South African spell check does even worse things. So I think stick to your Nigerian spell check. Other questions from here? I think everyone's bursting.
Maybe I can tell you something. We did a study on the first trimester detection of anomalies, and surprisingly, we found a very low incidence of false positive But the big difference was that the study was performed by people with experience in first trimester scan. So you have really, the bottom line is that you have really to get used to the normal anatomy, and then when you see that something is abnormal, with all the precautions that we have underlined, that you shouldn't rush into a decision, it seems as if the number of false positive is reassuringly low.